Now we will continue with our sessions. I invite Dr. Rammanohar, Research Director, Amrita School of Ayurveda, Kollam, to take the session on patient and public involvement in pharmacovigilance. I welcome you, sir.
Very good afternoon to all of you. So I hope you had a nice lunch. Maybe you're all feeling sleepy now. This is the most challenging session to handle immediately after lunch. So I'm sure you had a very enriching morning session with experts talking about different aspects of pharmacovigilance. I wanted to discuss a topic that is not usually given much attention. It's about the role of patients in pharmacovigilance. So this is a topic that is gaining importance globally. So when we usually think of pharmacovigilance, we think of how clinicians can report, right? But now we are looking at patient as a major contributor to the development of pharmacovigilance. So in this area, we have a lot of concerns. Primarily, we would think, do patients have the kind of expertise, to participate in pharmacovigilance? Will they have all the technical know-how? When a patient is involved in reporting pharmacovigilance, will we get more misinformation than proper information? This is a concern. Is that not? Because when doctors are, reporting, they have a background. I mean, they are able to sift between what is likely to be a real adverse event, what is not likely to be adverse event. So I got interested in this topic and started reading a lot about it, and I was surprised at the findings of how, and that is what I want to share with all of you today, especially at a global level. I don't know whether these things will apply to India, because in India, literacy, awareness, all these things are very varied. When it comes to the developed nations, the findings from their efforts in involving patients in pharmacovigilance is quite revealing, and that's what I would like to discuss today. So, with reference to our own classics, there is just one sloka in Charaka Samhita which is talking about a patient's perspective of the effects of treatment, especially of the harms of treatment. So in the Sutrasthana, first chapter of Charaka Samhita, there is a verse, Tasmad na bhishaja yuktam, yuktibahyena bheshajam, dhimada kinchit adeyam, jivid arogya kankshina. I was intrigued by this because, especially when I was discussing with some Western historians on ethics, they said that in our textbooks there is only physician's perspective. There is no patient perspective. That everything is, centered around the physician. The physician decides what is right or wrong. There is no voice of the patient. So this sloka struck me because I was seeing the voice of the patient here. So what the Acharya is telling is, for these reasons, tasmad, and those reasons we will explain, bhishaja yuktam, yukti bahyena yuktam. If a physician gives you irrational treatment, so now this is fascinating because Charaka Samhita is talking, suddenly the gaze is changing from that student or physicians to the public. There is a discourse going on, and suddenly it is like Acharya Charaka is looking outside and giving a warning to the public. He says that yukti bahyena bheshajam bhishaja yuktam na adeyam. So that chapter is discussing a lot about rational treatment, how treatment should be made rational, how we have to make sure it is safe. So the definition of Beshaja, this is the place where there is another sloka, just not coming to my mind. I'll get back to that, where the warning is given to the physicians how to make their treatment really safe, complete, rational. And it is at that point that Charaka makes this statement. So, Jivid Arogya Kankshina Yuktibahyena bhishaja yuktam bheshajam na adeyam. So this is the right given to the patient. That as a patient I have the right. I mean, just imagine 3000 years ago, patient empowerment in the Charaka Samhita is something you cannot imagine. That the patient is given the freedom to question the Vaidya and deny the treatment if they feel that it is not rational. So which means that today a patient has the right, even according to Charaka Samhita, to ask the clinician what is the yukti behind this. And so, because generally this is what those Western scholars also said, that in our tradition, the Ayurvedic tradition, the whole idea was absolute faith and belief in the physician. The physician deciding whatever has to be given and the patient unquestioningly accepting all that. But if you look at this verse from the Charaka Samhita, it gives us a completely different perspective. That the patient can question. The patient should be a participant in this whole, a decision-making participant in the whole process of consultation and receiving the treatment. Patient has the right to know what is the rationale behind the treatment. Patient has the right to question if something goes wrong, was it due to the treatment? And so that is, so for Jeevitam and Arogyam, two things he says, these side effects or which is sometimes today called as medical error. There are some exaggerated reports also. Like in the US, there was an article in the BMJ which later has been termed as a little bit exaggerated, but there is some truth in it, that the number one killer disease is cancer, heart disease. The number two killer disease is cancer, and number three is the doctor. This is a kind of news that is circulating in medical journals, but then there are questions also about how good the statistics was, that it's a little extrapolation and exaggeration. But still the fact is that medical error is quite high. And without the participation of the patient, we will not be able to detect these incidences, especially what we have seen with our pharmacovigilance center is it's very, very difficult to get doctors to comply and report, adverse events. And it may be much more easier if patients are participating. We will be able to get much more recordings of adverse events, which could then be screened by a group of physicians, and out of that we can pick up the ones that are really, meaningful. But what I have to present here today is really very interesting, because in recent years, patient participation in the surveillance of safety of drugs used in clinical practice has become more important. Current trends in pharmacovigilance systems are veering towards what we call as spontaneous reporting. Spontaneous reporting is, when something happens, immediately report it. It is not done through other, proactive ways of collecting data on adverse events, where you have adverse event forms and all that. Here, when something happens, so spontaneous reporting is one way to get data on pharmacovigilance, and patient involvement is being considered very important globally. So what do we mean by patient participation here? It means that the patients will directly provide first-hand information, not through the doctor. The patient has a direct contact to the pharmacovigilance cell. Usually patients may report to the clinician, but the clinician actually is most of the time biased. That is what we have found in these studies, is the clinician is more biased than the patient. So it is more likely that the patient will report a ADR more effectively and more comprehensively than a physician. So this is the patient participation creates a situation where they can explain, they can narrate their ADRs without the filter or interpretation of a healthcare professional. This is very important. This is what is meant by patient participation. Patient participation does not mean that as a clinician you are sitting in your clinic and then you are telling all your patients, sensitizing them to report to you. That is not the kind of patient participation we are talking about. Here patients will directly report to the pharmacovigilance cell without the intervention of it, because that bias or that influence is avoided. And this is actually contributing, because in modern medicine, post-marketing surveillance is so important. The studies are done in very controlled settings, very limited population being exposed to it. It's only during the post-marketing surveillance that we can get more, detailed ideas about the safety issues of a particular drug. And even now, there is new pharmacovigilance data about even paracetamol. Recently, you can see newer and newer information coming as more and more people start using it in different ways. So this is very important. So I hope the point of what you mean by patient participation is clear here. It is a direct, reporting to the pharmacovigilance department. So why is patient participation so important? Because we know before drugs are marketed, they do undergo extensive risk assessment. They are subjected to clinical trials. There is, in all clinical trials, we know adverse event reporting is a very important component. We have very detailed format forms where in the clinical studies, we did a study in Coimbatore and it was fun. We were recording and reporting any event. If the patient sneezes, that is also an adverse event. So we had numerically, very large number of, so that was a good experience to see. And of course, then we had to filter them. But when we were recording, we were giving the benefit of doubt. Any kind of adverse event would be recorded. So clinical trials are also quite, if they are well conducted, they are designed to be able to detect as many adverse events as possible. But the problem is these pre-marketing clinical trials are small and homogeneous, and they work only on highly selected populations. They are monitored only for short periods of time. So not all possible adverse drug reactions are detected. In real world, when they are used, there are so many new things that will come. And so this is because the aim of pharmacovigilance is the timely detection of new drug safety signals. Okay, this is almost like a repetition. Yes. So I'm just now talking about, again, emphasizing what is the need for patient participation. So I hope it is clear that even if drugs are subjected to good clinical trials, we would still need adverse drug reaction data. And normally we are collecting this data through three major sources. One is spontaneous reports, then clinical trials and observational studies. Now we are going to talk about spontaneous reporting. And in spontaneous reporting, patient participation is one of the major factors. So today when we are talking about spontaneous reporting, we are mostly thinking about physicians only. And that is a shift in perception that we need to bring in. Not only physicians, but patients are also to be made part of the. So why has there been thinking globally on why patients should also participate? It is because healthcare professionals are underreporting ADRs. And now we are talking here about modern medicine. This is in the field of modern medicine. Modern medicine generally, compared to Ayurveda, there is more reporting. But that itself is considered as gross underreporting. If you look at global pharmacovigilance standards, it is not satisfactory. A lot of incidents are being mixed, a lot of signals are not being detected. And it is this situation that has led to the realization that patients could fill this gap. So main causes are ignorance amongst practitioners. There is a feeling that only serious, as I told you when we did our trial, everything we noted down at the first level, everything was noted down. This is a misconception that only really serious adverse events should be reported. Then there is lethargy. Many people are not interested. It is a waste of, it's a lack of time, the cumbersome procedure that you have to follow. Complacency is believing so these findings are there based on interviews, surveys, actual exploration of the regular scenario. So we can also look at our own attitudes here. The general feeling this may be true. Complacency is there in Ayurvedic community. This is what I feel. We have not done a survey, but if we do a survey, we might come to this conclusion that we believe that only well tolerated drugs are marketed. Our medicines are beyond side effects. So there is no chance that even if a side effect happens, it's very unlikely that it is due to our medicine. But when you're thinking pharmacovigilance, your thought process is totally reverse. You are thinking in the opposite way, that anything happens, you give the benefit of, is it due to our medicine? So this shift in perception has to come. So complacency is one major factor with practitioners. Then diffidence, the fear of appearing stupid when a react. So that's why I mentioned about sneezing and all that. You may wonder whether a patient fell down, broke his leg, we put that also as an adverse event. Everything was recorded. So when, anything that a patient experienced during the time they were in our trial was recorded, and we got numerically a large number of events can happen. And then the question comes as to which ones are really, related to the treatment or not. So many a time, I think this, I have seen in Ayurveda community, the second, complacency and diffidence, both are there. Many Ayurveda physicians may think, if I tell this, I will be singled out, as a troublemonger, or I may be wrong. So you don't have that boldness to come and report a particular observation. Then, of course, this third thing is also true, I think, with the Ayurvedic community, as feeling of insecurity. Now, if I start reporting that from my own practice, there are adverse events happening, you may feel very insecure and fearful. Then, of course, high workload, administrative burden, these are all the causes for underreporting. So what we have I can say with my experience in this pharmacovigilance center, that what we have been able to churn out in the last few years is nothing. It's actually, nothing has been implemented. What has been done is trying to create more and more awareness, conducting camps, conducting seminars, webinars like that. But if you look at the outcomes, how much adverse events are being actually reported, then it is nothing. So highly performing, I don't want to say performing centers, I looked at the data. So if that is what you mean by highly performing, then we are really in trouble. So there is a real change that we need to begin, and that is the reason why I started thinking about, can we start telling our patients who come to our hospital, you please report. We'll tell you where to report. Our clinicians are not going to report. And then I didn't even know that patients could. It was an idea that came to my mind. That why can't we ask patients to report? They are the affected people. And then I found that there is a whole system developed globally on patient participation. And then I thought, I think we should disclose this to our clinicians, threatening them that if you don't do this, patients are going to actually start reporting the adverse events. So that is the purpose of today's discussion. So patient participation, actually it's not been very common in pharmacovigilance practices. And the main reason is the concern that patients may lack medical knowledge. And so this is one thing any practitioner would feel. How can a patient decide whether it is? We would also shut up a patient's mouth if they come with such, doctor, I took this medicine, I got itching. Then you will say, no way, it's not possible. With that medicine, it will not happen. This is the attitude generally of a practitioner, especially in Ayurveda, where we do not have documentation of what are possible side effects. It's very difficult to correlate. If it's a modern drug, if you look at the literature, you can at least know what are the most frequently encountered side effects. They have a category, rare side effects, most frequently life-threatening, serious side effects. It's all classified. But in Ayurveda, it's very easy to brush aside any concern a patient comes up with, because there is no documentation or no association. So this is the reason why reporting of possible ADRs was mainly reserved for healthcare professionals. But you will be surprised, only a few countries allowed patients to report their drug concerns directly to the National Pharmacovigilance Center, amongst which we have Australia since 1964. And I want to give Australia as a case study. At the end of our discussion, I will show you how Australia is reaching out to their patients to get pharmacovigilance data. And I strongly think in India, and especially in the Ayurvedic field, if we can do this, our whole pharmacovigilance system will undergo a major revolution. And the USA has also been doing this since 1969. So, just in that gap, I was also born. So, so I can say that pharmacovigilance has been, patient pharmacovigilance was almost born with me. Since we have crossed more than half a century, but in India we are still not, many of us are not even aware that such a thing has happened, worldwide. So, but over the years, especially in recent times, there has been a change in attitude in which patients' experiences are valued. So, in the 2000s, after 1960s, then it was in 2000s that there has been an explosion. A lot of countries implemented patient reporting systems. I read also a whole thesis works of people who have done PhD work on how patients can better report pharmacovigilance. Very interesting. So Denmark, Netherlands were the first European countries in 2003, Italy in 2004, UK in 2005, and Sweden in 2008 started involving patients in pharmacovigilance. I think many of you may have also been born by this time when it all started in Europe. So also outside Europe, countries were making efforts to accept reports directly from patients. So Malaysia, Philippines, they all started this. So now this is already, that's the point I want to make, it's not something new. And what I want to share is what did these countries learn through this experience? They are saying that it is, what are they saying? Is it valuable or is it misleading? That's what we will look at now. So in Europe, the role of patients as stakeholders in pharmacovigilance became official after the implementation of the pharmacovigilance legislation in July 2012. So about 12 years ago. So this legislation enabled patients throughout the EU, the entire European Union, any patient can report adverse event directly to the national center without any interference of healthcare professionals. They don't have to go through healthcare professionals. So patients are also part of the pharmacovigilance system, national. The patient representative plays an invaluable role in ensuring that regulators remember to take the patient perspective into account. So patients are included in these pharmacovigilance committees and so I think this is a good sign. We all have pharmacovigilance cells, units. It would be good to have one patient also in your cell. So you get their viewpoint, their participation. They can also help and spread awareness. Why can't we think about that? This is my serious question. So we should encourage patients to report adverse events because they report an adverse event, and we tell them that if you have a doubt, please report. That is the principle. If you doubt that it is an adverse drug reaction, because ADR is not an adverse event is not always an adverse drug reaction. So we can always, later, that is why the signal detection is the next important stage. So when you compile all the adverse events, you don't need to be so worried about it will all be attributed to our drug. There is another system where this analysis will be done. So what is the reason is when a healthcare professional, what has been found is if healthcare professional reports an adverse event, only part of the story is reported. So it is like the healthcare professional sitting with a scissor, cutting and pruning, making it into a nice shape, and then only they will deposit it in the pharmacovigilance center. So the patient perspective is mostly lost, completely lost. So direct, that is the reason why direct patient reporting should be there, because it gives you a completely different perspective. Because the patient is the person who is actually experiencing that adverse event. So a physician, a healthcare professional's judgment of what the patient has experienced is what is getting reported as a adverse event, not actually what the patient is experiencing. So we need to get a first-hand access to what is it that the patient is actually experiencing. So what is it? So there are many aspects in an adverse event. What type of adverse events do patients report? So sometimes if it is very sensitive, embarrassing, they may not report. That has also been found. So there are studies, I am not going into the details, we don't have time for that. I just wanted to highlight that this has been very extensively studied. What are the kind of adverse events that patients are likely to report? What are the ones they are not likely to report? So what can we actually expect from the patients? The second thing that has been well studied, there are so many papers, at least a few hundred papers I was able to check on our research databases on patient involvement in pharmacovigilance. Many studies done to see. So what is the quality of the information? When patients report, is the quality good enough? So why I am saying is, these things have already been studied. Now you may have all these questions in your mind, but they have been studied, they have been reported, systems are in place. And I was surprised that we started our pharmacovigilance in 2020. It is only in the last few months that I became aware of it. So somehow in our whole pharmacovigilance, ecosystem, this has never been highlighted. It's very, very surprising. Next is the contribution to signal detection. This is also fascinating. When I was reading it, I thought from them we will get mostly false signals, but it's not true. Patient reporting has enabled to recognize a lot of signals related to adverse drug reactions. It has proved to be actually very valuable. So studies have clearly indicated that they fill a much needed gap in pharmacovigilance reporting. Then practice of pharmacovigilance in terms of feedback for patients. This is a very, very important thing. Patients like to get feedback. They will come and report something, and after that there is no noise. No response. Now this can be very frustrating for a patient. They want a closure. If I submit a report to the pharmacovigilance center, will there be a feedback? The patient should be given an assurance. That is the whole purpose. So if you want to improve patient compliance in pharmacovigilance, this system should also be there, that we reach back to the patient and tell them that this has been analyzed, this is the feedback you are giving, and it is through that system that we can nurture this whole process. So how good are patient reports in pharmacovigilance? Studies demonstrated that patients are capable to provide a detailed description of the ADR. I don't know in India whether this will hold good, depending on literacy, population, it may vary. We may not be able to get homogeneously similar kind of ADR reporting. A study in Netherlands demonstrated that the outcome of ADR was reported in over 85% of all patient reports versus 68% of healthcare professionals. So patients were better than healthcare professionals in reporting ADRs. Is that not surprising? I thought when I was screening all this data, I was thinking that maybe they will come a little close to the healthcare professional, but patients have reported in much more detail, much more accurately. So another important thing, which is very, very crucial, serious adverse event, non-recovery from the adverse drug reaction. This is reported more by patients than by healthcare professionals. So a lot of important data would be missed if patients don't give that feedback. They have not recovered. Irreversible adverse drug reactions are better reported by patients. And then patients generally provide much richer descriptions of behavioral phenomena and feelings than healthcare professionals. So, for example, patients are generally better in explaining the nature, significance, and consequences of ADRs than healthcare professionals. So, from all the studies done in Europe, USA, Australia, of course, they are more prosperous countries with population profile very different from India. So, what we have to see now is I did not find any such studies related to the Indian population. So this is something we must really look at, how effective our own population will be, and can we use this patient-based approach to improve our pharmacovigilance reporting system. Now, contribution of patient reports to signal detection. It's another question. Did they really contribute? So studies demonstrated that there is an upward trend in the contribution of patient report to signal detection. In the UK, the proportion of signals for which ADR reports from patients contributed increased from 15.6 to 23.6. So patients are getting better. If you start encouraging them to report ADRs, they are getting better, and there are more signals being detected from their reports. So in Netherlands, the Pharmacovigilance centers accepted patient reporting in 2003. Number of reports directly from patients in the signals rose from 10% to 28.3%. It's also again a huge increase. I can see this post-lunch session is affecting some of you. So brain fog is very visible on some of the faces here. So patient perception versus that of healthcare professionals. Patients mentioned that the severity of ADRs and the impact on their daily life were important subjects. Whereas healthcare professionals and patients are thinking in different ways. The patient is thinking about how it affects so when a patient reports, they are likely to focus more on how the adverse event is affecting their life, their well-being, whereas a clinician is more concerned whether it is really due to the drug or not. So that is why they miss a lot of these adverse events. So we will never know what is important for the patient. Patient is least bothered about causality there. Patient is bothered about what is affecting me. And so when patients report it, we get a much clearer picture of how the patient population is really affected by that side effect. So some side effects may have a strong causal link to a medicine, but may not be bothering the patients much. It may not be much of a bother for the patient. So patients reported the impact of the ADR and the patient's weight and height more frequently than healthcare professionals, whereas healthcare professionals reported the route of administration of the drug and medical history more frequently. So there's a big difference in the way medical professionals and patients report the adverse drug reactions. So patients were, again there are differences, patients were more likely. So now this is what I want to ask. Given that these are the findings, what is your opinion? Do you think, would you really consider encouraging your patients to, or will that be a threat to your clinical practice? What is your impression so far? Can patients play a big role? But then are we willing to take that risk? Eh? First. True, but what we have, what we have found here, that's what I showed the data. It's contrary to our beliefs. patients scored better than healthcare professionals in all the countries which were studied. I don't know what will be the situation in India, because India patients may not be so well educated always.
Even a surgery failure is actually damaging the hospital or something like
That
that.
is a problem. That
Attitude
yeah,
disease.
yeah, yeah.
Foreign countries.
No. So we are not talking about healthcare professional versus patient. This is an attempt to get additionally an input from the patient, and it is not taking it just in face value. It would be further subjected to all causality assessments, and then only it will be accepted. But then you give a see. It may also have positive implications, because uh, if such a system is there, think of the fact that it may have a positive impact on the patient also, because now they feel confident that if something happens, there is a way to express it, and that they will get a feedback. The feedback is very important. We should not just encourage them to report it, but they should be given a feedback, and there will be a closure for that whole process. That might eventually give more confidence, and change, bring a big shift in perception. Today I think all this violence and all that is also because doctors create a big wall between themselves and the patients. Patient concerns are not adequately addressed. If a patient is told beforehand of all the possibilities what they can do, and they take an informed decision, then there won't be so much of a issue. So again you can see advantages. Patients were more likely than healthcare professionals to report the outcome of the ADR, a detailed description of what happened, the severity, contact with or between healthcare professionals, and the patient's thoughts also about causality. So it all depends on how we collect the data from them. Healthcare professionals were more likely than patients to report about certain things like drug dosage, the pharmaceutical forms of the drug, other suspected medication. So what you can see is they are complementary. Unless we get information but from both, so why can't we also think of, when an adverse event form is filled, get the health professionals version and also a patient version, because then we'll see both sides of the situation, and then the data will be much more complete. So this study concluded that patient reports are more focused on patient related information and the impact of ADRs, whereas reports from healthcare professionals provide more clinically related information. So all these things are very clearly pointing to the role that patients can play in making pharmacovigilance reporting more efficient and more complete. It's not a question of healthcare professional versus patients. It's a question of healthcare professionals and patients. So when a patient reports an adverse event, and if a healthcare professional has to comment on it, then they will also be forced to add their perspective on it. So we could have an online system where when the patient reports and the particular practitioner is mentioned there, the link will go to the practitioner also. Now the practitioner will be forced to write their own opinions and perspectives. Then we get the complete picture. Now this is very wishful thinking. I'm just thinking aloud. I don't know how we can implement it. But if we are implementing it, maybe it will be first initiative in the field of Ayurveda, and we can see its outcomes. So, clinical information is needed to assess the causal relationship between a drug and an ADR in a reliable way, and studies indicate that patients reports clinical information at a similar level as healthcare professional. So patient reports can also help in signal detection. Many a time we miss all these things. Now this is the most interesting thing. Many of us may not be aware, but in India it is possible for patients to report ADRs to the Pharmacovigilance program of India. So India has also very silently taken this up. Nobody knows it, so that is their way of not making it happen, I think. If you ask legally if there is a way, yes, there is. It's there in the form. No, I'm just joking. So, Patients can report adverse drug reactions to Pharmacovigilance Program of India, which means they can directly report suspected side effects from medications to the relevant authorities. This is done through the medicine side effect reporting form for consumers and can be submitted via the toll-free helpline, email, or by visiting an adverse drug reaction monitoring center. But the thing is, if patients, there's not adequate efforts being taken to bring patients to make use of these. That is a problem in India. Whereas if you look at other countries, there's a lot of effort. And I want to show Australia as an example, as a case study, because they're one of the pioneers in this field of patient-based pharmacovigilance drug reporting. So, what do you mean by patient participation? Direct reporting. Patients can directly report their adverse drug reactions through dedicated reporting systems, often online or through a phone hotline. Patients can provide unique information about the impact of a drug on daily life, including details that may not be captured by healthcare professionals. Then identifying safety issues. By actively reporting adverse events, patients can help identify potential safety concerns with a drug that might otherwise go unnoticed. Patient education, raising awareness amongst patients. This is the key thing. I mean, if we don't put the effort, especially in India, we will need to sensitize the patients too. So what is the time? I don't know if I am 3. Okay, so I think I must quickly stop now. So patients can participate by reporting adverse events. There are patient registries, patients feedback surveys. So there are many ways in which patients can participate. And through patient participation, we can have improved drug safety monitoring, enhanced patient empowerment, and a more comprehensive safety profile. In fact, it can improve patient satisfaction in the whole, clinical encounters, because they know that there is a possibility that they can interact with healthcare professionals about concerns before, during, and even after the treatment. When this kind of communication is not there, that is what is creating a lot of distrust between the patients and the practitioners. So the challenges are the variation in health literacy, meeting consumer expectations, translating assessment of benefit risk at the population level to an individual consumer's experience. So variation in health literacy, this is a big thing in India. Everybody is not having the same. Then regulatory issues, vexatious complaints, I mean, with grudge, or, patients may accuse a physician unnecessarily and make false claims. Incomplete information in AE reports, media interested and stimulated reporting, new technologies and social media, mistrust of government. So there are many challenges. But the opportunities are that you can have better engagement with health literate consumers and better education of consumers with lower levels of health literacy. So this way, the entire relationship between the healthcare professionals and patients can change for good. Even though initially there is a fear that they are going to report more, it's going to be more transparent, but actually it is going to build up trust in the long run. So better collaboration with industry to encourage patient involvement in pharmacovigilance, better engagement with mainstream media to create positive news stories, international collaboration and adoption. So I'm not going into all the details. There are a lot of pluses and minuses, and we have to weigh the pros and cons and then take a call on how we will. The mechanisms are there, even in India the mechanism is there, but how do we? So last point I will quickly go through is Australian experience, what Australia is doing to enhance. So even though Australia has incorporated patient participation pharmacovigilance since 1967, Australian Government Department of Health Therapeutic Good, TGA, is very much committed to safeguard the public, and so they are taking a lot of initiatives here. So patient empowerment, encouraging the patient to, they are just sitting there to create awareness, create more patient participation. So what they found is that there is a decrease in reports from consumers from 2011 to 2014, and they initiated a project called the Consumer Knowledge Adverse Event Reporting Project. It's called as a clever project. So through this project, they are taken the effort to sensitize patients, improve the adverse event. See, the problem with us in India is we bring systems, we create mechanisms, but actually it doesn't get actually implemented. The stakeholders are not sensitized enough. So Australia has been doing this, and their clever project is, it's a big collaboration. Let me not go into the details. I have to conclude now. Qualitative study using focus groups to explore consumers' opinions about adverse events associated with medicines, vaccines, medical devices. So the clever project findings are that the participants saw value in reporting for themselves and the greater medicine taking population to improve safety. So this project actually worked. To put a big story short, for lack of time, so they got a lot of opinion from consumers regarding how to make this process more easy. Reporting had to be easy, accessible, and time efficient. Consumers would like feedback for the one of the major motivation they found. If consumers get a feedback after they are very much motivated to continue this process. So all those learnings were there. So some of the patient feedbacks, I would like to report it, but I am so busy running around, I am so forgetful that I would either forget if it wasn't easy and quick for me to do it, or just not have time to go somewhere to actually report it. If it was easy to report, I would definitely do it. So some people said, I think if you have got to jump through hoops and everything, answer a whole 30-page document, and you just go, couldn't be bothered. So then there are others who said, I prefer to report to the government because I feel like it would be taken more seriously than a call center or representative. So there were different patient perceptions. They worked around all these problems and brought the whole process back into track. So how did they do? They had a website content developed specifically for consumers. Link for reporting problems is prominent. Multiple ways consumers can report, including online form designed specially for consumers to report a side effect. They will get an acknowledgement letter with their ADR number. FAQs about frequent adverse event reporting, safety information. So they brought in a lot of mechanisms. I think this may be needed very different. So why I am telling this is, even though we have a concept, in order to actually implement it effectively, we may need country-specific approaches. So it's not enough that we just create a mechanism where they are said that you can, it will not happen that way. We have to reach out to the patients, we have to tailor a method that is relevant for our socio-cultural context, and then only it can be implemented. When it comes to pharmacovigilance, it's always about gaps in implementation. It's not about the concepts or ideas. They are all very clear, very fascinating when you listen. But at the ground level, how much and what is happening is always a matter of concern. So here are a few examples of studies that you can see. This is being very extensively studied. Nothing in the Indian context yet. So there's a project going on that aims, these are latest papers, that co-design a digital reporting platform to improve detection and management of adverse medical events by consumers and healthcare professionals, and to improve reporting to regulators. How could employing the patient perspective? So these are, from new papers. So, and I would like to also conclude by pointing out a very interesting book that I came across recently. It's a Springer publication, Principles and Practice of Pharmacovigilance and Drug Safety, published in August 2024. And there is also one fascinating chapter on patient and public involvement in pharmacovigilance. So these are some further readings. So I pointed out in the PubMed database or Scopus, if you search for articles on patient participation pharmacovigilance, you can get interesting information. And I picked up a few papers in the last 2 months that came up in the journals, and this is one of the latest interesting books where multiple aspects of pharmacovigilance are actually dealt with in detail. So with that, I will conclude. Thank you for your attention, especially in a difficult period after a heavy meal. Okay.
Thank you, sir. I invite Dr. Ramesh Anvi to present the token of love.